such as arthritis, chronic diabetic ulcer, or psoriasis. And although the bolus dose of drug, either you take the drug orally or injection, these conventional treatment still cannot solve the healthcare burdens. For example, the high relapse rates or unpredictable flare-ups that disturb the patient's daily life. And because there are a wide range of disease condition, it's very difficult to develop one dose of drug that can be used for all the patients. And last but not least, that is the side effects. When people take the conventional treatment so frequently, they will have a higher risk of stroke or heart attack. So nowadays, we believe that there's an unmet need of personalized and precision medicine for effectiveness management of inflammation and pain. And the meaning of personalized and precision medicine, that means that there will be a system which can sense the severity of inflammation and release the drug according to the level of inflammation. So when we look through the literature, we found there's a correlation between the upregulation of MNI, which is a protease, and different inflammation-related diseases such as arthritis or chronic wound or foot ulcers. So we believe that by design a drug delivery system which can sense the level of MNI, which is the protease, we can have a drug delivery system which can be responsible to inflammation to serve the purpose of designing precision medicine. So as you can see on the slide, this is our very first generation platform. We call it a response platform technology. So this is a hybrid hydrogel for protease trigger drug delivery. And this whole platform consists of three different components: the drug-loaded PLJ particles, the peptides, and the forearm pigment and so forth. So by combining the three components, we will have our hybrid hydrogel, which is response to MMNI to release the drug. And without MMNI, the hydrogel will stay intact and there will be no drug release. Yes, and one of the advantages of this system is that the framework itself is very generalizable. That means we can change the drug choice or the loading capacity or even the sensitivity of system to be suitable to a disease of interest. And when we test our system in vitro, that means with the cells, we see that the MMNI, which is the protein of interest, the biomarker that trigger the release of a drug, and the drug when released will suppress the TNF-alpha secretion. And TNF-alpha here it is the central biomarker of inflammation. So when the amount of TNF-alpha is suppressed, that means the severity of the inflammation is also suppressed. And nowadays in the market, there will be a lot of products they target to suppress the TNF-alpha. And on your left-hand side is the drug release of our system compared to conventional release. So with the conventional release, there will be the huge burst release that cause a lot of side effects. And with our platform delivery system, which is the blue line, the control release is much under the control. So moving forward, we would like to optimize the platform even further by directly conjugate a drug into the platform. So because of that, we can minimize the use of microparticles in the system. Because in one of our previous study, we showed that the PLJ particles, even though it is well used in drug delivery system, the polymer itself also cause a lot of side effect, cause a lot of host response. And with the use of microparticles, technically the burst release is still there. We can only minimize the drug release, but we cannot eliminate the burst release. So the idea here is we will conjugate the drug, which is the green color diprofen, into the hydrogel backbone, and then we'll cross-link the hydrogel to have our drug delivery system. And again, we choose our protease MMNI as a model of protease to show the proof of concept. And with the present MMNI, the MMNI will cleave the hydrogel to release a drug. And as you can see on your left-hand side, because when we conjugate the drug, in this case is ibuprofen to hydrogel, we somewhat modify the structure of ibuprofen. So there will be a concern that after the modification, is the ibuprofen still effective? And because of that, we did a study to compare the therapeutic effects of the ibuprofen and modified ibuprofen. At the same time, we also compare the cytotoxicity of the native ibuprofen and the modified ibuprofen. So as you can see on your left-hand side, the bar graph showing the cytotoxicity of the drugs, and compared to the native ibuprofen, the unmodified ibuprofen in black, no, in gray, our modified ibuprofen, which is the black bar, show a less toxic compared to the gray bar, which is the ibuprofen. And at the same time, when you look at the two lines, which show the therapeutic effects of the drugs in terms of suppressing TNF alpha, our modified ibuprofen still preserve the therapeutic effects. And on your right-hand side is the experiment we designed to check the trigger release of the hydrogel to suppress the TNF secretion. So the idea is that when we immerse our hydrogel into the culture media, because of the presence of the MMP9 protease in the culture media, the MMP9 will digest the hydrogel to release the drug. And the amount of drug release will suppress the TNF secretion from the raw macrophages, which is one of the cell line in the immune system. So look at the two bars in the red box. You can see that with the presence of the MMP9, the MMP9 did digest the hydrogel to release a drug, and the amount of drug release still preserve its activity in suppressing the TNF alpha. So moving forward, we would like to test our hydrogel system in mouse, which is in a rodent model, and to illustrate the information responsive release concept, we need to design a mouse model which has 3 different levels of information stability. So because in the literature, in the field, there's no such model available for us, so we need to kind of establish one model by ourselves using stimulants, chemical stimulants. That means we will inject the stimulant in the dorsal side of the mouse, on the back of the mouse, and with different dose of stimulants, we will achieve different levels of information stability. So as you can see in the color photograph here, if the information is more severe, the reddish area will be more obvious and bigger in size. And at the same time, when we look at the fluorescent microscope, and this fluorescent microscope is applied by injecting fluorescent dye into the mouse. And that fluorescent dye will detect the protease activity. So if you can see a higher signal of fluorescent dye, that means the protease activity is stronger, showing a more severe information. And the more severe information correlates with the higher dose of stimulants. So when we quantify the fluorescent signal, we see that with the higher dose, we have a higher fluorescent signal. And we also retrieve the tissue to quantify the amount of MMP9 protease. And you can see that with the higher dose of stimulants, we will have a higher amount of MMP9 secreted. That means that we can establish an information models in mouse with 3 different levels of information. So moving forward, we inject the same amount of hydrogel into the implant site. And on your right hand side here is a skin tissue of the implant site and the hydrogel injected. So when we quantify the amount of release, we see that with a high with a higher dose of stimulants, that means the higher severe of the intervention, there will be more drug release, and less severe intervention correlates to less amount of drug release. So this is the first time in the field the intervention responsive drug release can be illustrated in mouse model, in an animal model. And not only our hydrogel can release the drug correlating to the severity of inflammation, the drug release out of our hydrogel system still preserve its activity in suppressing the TNF-alpha secretion in the mouse model, showing on the graph at the right down corner. Yeah. So for the brief conclusion, in our lab, now we can develop a protease responsive drug delivery system with the flexibility in tuning the drug loading capacity and the drug release rate. We also establish a new subcutaneous inflammation in mice with varied levels of severity. And with that model, we can demonstrate a robust in vivo inflammation responsive drug release, and the system still preserve the anti-inflammatory effects. So this is a potential platform technology that can be used for multiple inflammatory diseases. And as of now, in our lab, we are pursuing two different indications, which is the arthritis and the chronic wound. So hopefully we can have a new updates about our data in near future. And for all of that, I would like to thank our lab members, our cooperation, and all the funding resources. Yeah, and I would like to hear on the comments and questions from the audience.
Great, thank you very much, Dang. So just a quick question. Can you go to the slide where you do the cumulative release? So how do you see the signal coming out? Is this like the very first one?
Do you mean this slide or the?
No,
this slide.
Yes, this one. Yes. This so one, you got this one, and then when you say that cumulative release, but that what signal does it come out for you to do the measuring?
Yes. Generally, we immerse our hybrid hydrogel into buffer, and at the predetermined time point, we will aliquot the supernatant of that buffer and run through HPLC to determine the amount of drug release at that time point. Yeah.
Okay, so it's an actual direct drug.
Yes, correct.
Okay. So then another question is that you want to have a slow release instead of the burst release. Do you do you want to have a correlation of the actual release and efficacy? So sometimes you want to have a very high dose to have a efficacy effectiveness. Sometimes you want it slows release. So it depends on the different disease that what mode of release that best, because sometimes, as you know, that two of the things that if you're going to take orally, it's very slow, but if you're going to take the injection, it very fast go to the blood. So how you going to correlate that which modes of action is good for which disease?
Oh, so I think, first of all, thank you so much about your very in-depth question. And for this platform technology, right, the actual drug release mechanism really depends on the disease of interest.
Yeah, sure. Yeah. So very Okay, of course, it depends on the disease of interest. But then the question is here that for a disease, let's say arthritis, and
Yeah.
do you have a correlation or some kind of prediction or some kind of you anticipate that you want it released for 24 hours instead of 4 hours?
Mm, mm.
And
Yes.
how how you control that this effective is good. If come back to oh yeah, you want to say that? Okay.
Yes.
Yeah.
Correct.
Okay, if
Yes.
you want
So
to explain, that's fine. Yeah, that's because I'm interested. Thank you.
yes. Thanks a lot about your question and your interest as well. So as of nowadays, right? I don't find any arthritis model with different severity levels. That's just a limit to the system. So rather than using directly to the arthritis model, we here in the lab we develop our own disease model. I wouldn't say disease model, our own information model with different levels of severity. As you can see here, yes, we can have at least 3 different levels of severity: a healthy one, a medium severity, and a very high severity, as you can see. So move to the next slide. With 3 different levels of severity, we can have the amount of drug release at 3 different doses, at 3 different rates. Higher release rate correlates with a very high severity. A medium release rate correlates with the medium severity, and the control one, that means in the normal cases. Easy answer your question, and that is the first set of data. The second set of data is that here in the right down corner, that means the amount of drug release from our system in vivo can preserve the inhibitory effects to suppress the TNF-alpha secretion.
Okay, so you got your own system, but I'm just making it now more generic to any drug release because there is so many different drugs, so many different application, and link and chip in here as well. So the question I have it here is that we have a choice that
Yes.
either we're going to have a burst effect or burst release, or we have something mild, like we're going to make lower dose, or or you call it like a slow release.
Yeah.
But then it's really one that with these modes of action, do I or do anybody have a model so that I can monitor or determine or estimate that these modes of action of release is better for the disease? It's either cell model or the animal model. It's important because
Yes.
if something is well known, then obviously
Yeah.
I'm asking whether it's already literature that
Yes.
people are very sick because you release too much drug at the same time. That is a side effect, and you reduce the side effect. But when you reduce the side effect, you might also reduce the efficacy. So the question I have is like, do we have some either literature to say that the disease you need better to release over 24 hours instead of 4 hours? Then that's fine. That's all well done. But in the case that you have a new disease, you have a new drug, or not new disease, and let's say that the disease that is no drugs, it has been developed, and then you want to see that how it's going to release, and you correlate the mode of release to efficacy. So the question I have here is that the mode of release, either burst or slow, with the efficacy, which one is better? So for example, like if you whack something very strong and very fast, it's more effective than you do it mild and slowly. So that the question come back to really general thing. Do we have a model, either cell or animal, that we can determine that these most release is better? Because Because in the end of the day, okay, side effect is one thing, but is there something consensus? I just want to know. I mean, I just don't.
Yes, I agree. This thing I agree. So I would say, to be honest, to design such an animal models to answer this question directly, to directly answer this question is pretty hard. From what we know, for example, from what involve arthritis, because nowadays we trying to pursue arthritis as well. There's one situation in arthritis they call a flare. So the flare that can happen very unpredictable, and it can happen multiple times. So for the standard of care, they just inject a bolus dose of drug into the joint to hope that to suppress the flare. But because the bolus dose of drug they use is a steroid, is triamcinolone acetonide. That drug, even though it's effective, but there's a side effect. For example, they don't recommend the patient to take the steroid that triamcinolone acetonide into the joint every 3 months. They don't recommend that because of the side effect. So what we are proposing into our next study here is that we will have a side-by-side comparison between our hydrogel formulation and the bolus dose of that drug. We will inject into the joint, and to see, first of all, we can check the amount of drug in the plasma. So we predict that with our hydrogel system, the amount of drug can be detected in the plasma will be much less than a bolus dose. That's the first thing. Because with the less amount of drug in the plasma, the side effects will surely reduce. Yes, that's our thinking. And the second outcome we want to see here is the pain, the pain scoring. That means that either the patient or the rat lucky enough we have a rat model. I know in the literature there's a rat model to check the pain. That means if we can achieve a longer period of time without pain, that means that our system is more advantageous than a bolus dose.
Yes, so in that system you have advantages of less side effect, but what about the efficacy?
The efficacy will, I'm talking about the pain scoring. That means we will see how long either the patient or the animal, in this case is a rat, without the pain, can we achieve a longer period of time of pain-free compared to the bolus dose? So if we can achieve a longer period of time without the pain, that means we can show the efficacy.
So you got that model, that this animal model, for you to really compare these two things. So this is on the very specific system. So so that's fine. That you So you are saying that the burst, so actually the drug effectively maybe overdose. I think Linh want to say something.
Actually, Anirban here, and then he have something to comment on that. So
sure, please.
Hi, my name is Anirban, and I'm listening actually from the side of Lin, and I will be joining Professor Tan's group very soon. So I just want to comment here. I mean, I was listening. It's a very nice presentation, and you have done very good job here. But
thanks a lot.
In relation to Professor Tan's comment, I just want to say here, like Professor Tan was asking, the burst release and the slow release. What is the correlation between between them and the efficacy? But I want to clear it up here. Probably the point here of release studies, most of the drug release studies, is to see how to control the drug release. And from the release perspective, I think it is very important that most of the release, the initial burst is the main problem. Because when you see the pharmacodynamic or pharmacokinetic studies, we don't want a bunch of drug release in our serum at the beginning, and then it slows down. Rather than getting the very high concentration of drug in our blood or in serum, we'll be trying to develop a system that can release the drug in a controlled way.
Yes,
Right.
correct. Yes.
Not slowing, probably slow release is not the right
Yes,
term.
correct. Yes.
Rather than we should mention that the controlled release, because
Yes, I like the word control release. I like the word control release. Yes.
So technically, nowadays in the field, there are three main drug release mechanisms. The old one would be a bolus dose, I mean without any control, just a bolus dose drug. And the second term, the more advanced one, will be the sustained release. That means rather than having a huge burst release at the beginning, they control the release of the drug slowly in the control manner, in the sustained manner. And that mechanism is controlled by the characteristic of the drug delivery system, like the characteristics of the polymers or the hydrogel. That is the sustained release. But it's still not good enough, because the sustained release, it doesn't take into account the severity of the disease. And because of that, we have a third layer, the third layer of drug release mechanism, which is the inflammation responsive release. That means the release of a drug responds to the severity of the disease. That means if the disease is more severe, higher amount of drug will be released. If the disease is less severe, the lesser amount of drug will be released. That means the drug release rate is determined by the severity of the disease.
So you got the inflammation trigger, exactly the word. Yeah, actually your word, but also I was thinking, okay, inflammation trigger. Okay, yeah, got you. Okay, got it. Okay, I think this is very, very nice. Congratulations. Very interesting talk. Nhung, you are a chair, so are you taking off from the floor if there are any more questions?
Dạ, hello mọi người. Cảm ơn anh Đăng vì bởi
em hỏi xem là có ai có câu hỏi nữa không?
Thì cho anh Đăng không ạ?
Okay.
Okay. So by the way, Dang, if you have an email address, you might text into the chats that people might contact you or asking you the question or collaborate or as well, and say hello to Chum for me.
Yes, sure.
Great. Thank you very much.
Yeah.
Okay. So.
Okay, so chúng ta sẽ đến với phần thứ hai, bài báo cáo thứ hai của buổi seminar ngày hôm nay là của Dr. Trần Công Minh. Okay.
Hello. Stop sharing. Stop sharing.
Anh có thể share cái poster. Anh Đăng ơi, có thể share cái poster không?
Share poster lại hả? Okay, give me. Here, yeah, this one. Okay, yeah.
Okay. Sau phần seminar của anh Đăng thì mời các bạn đến với phần báo cáo, phần trình bày của anh Trần Công Minh. Anh là hiện tại đang làm research ở Đại học Oxford và anh sẽ nói về các hệ thống y tế và y sinh. Xin mời anh Minh có thể chia sẻ thêm về bản thân và bài talk và chia sẻ với mọi người bài talk ngày hôm nay.
Vâng, rất là cảm ơn mọi người, rất là cảm ơn Nhung, cảm ơn TYA, cảm ơn anh Chị Đăng và cảm ơn mọi người đã dành thời gian. Hôm nay là buổi cuối tuần, tối cuối tuần đã join cùng mọi người cùng mình nghe Chị Đăng để cùng nghe mình chia sẻ một chút những công việc của mình. Đầu tiên đấy là cho mình cảm ơn và cũng như là xin lỗi lúc đầu là mình có join muộn một chút, không có mất cái phần introduction của Chị Đăng, nhưng mà được nghe anh Chị Đăng có chia sẻ về những cái nghiên cứu của bạn làm thì mình thấy là nó thật sự rất là hay. Không biết là mình có record video không hay là mình nói có prefer là English or Vietnamese?
Có, mình ạ, có record vậy nên là mình có thể talk tiếng Anh hoặc tiếng
English em ơi.
Ok, thế cô Thanh đã đặt hàng như vậy thì chắc là em xin phép là chuyển sang English. Right, and so thank you very much. I'm so sorry for being late at the beginning. And today I've been give a talk about I'm glad to share about the work that I've been doing here, and also give you a couple of information about what I'm going to do in the future, and also if you willing to collaborate or join and just have a coffee chat online, please let me know. And I
Mình có
think I
hiện
will start by sharing my slides first. Okay. How many people are here in the groups as a student? Can you raise your hand? All right. I can't see any hand. All right. Can you see my screen?
Not yet em. Được rồi.
Okay. All right. I can't see any hands of the students, so that's good. I'm making an assumption that all of us have been working in the academia. And so a little bit about myself. My name is Minh Trần. I'm Vietnamese. I did my undergrad in biomedical engineering. So basically it's interdisciplinary combination of engineering, physics, medical science, and any other related subjects. And after complete my undergrad in the University of Sheffield, I had an internship in Oxford University, and I moved to Oxford to do my PhD. My PhD was about making the mechanical ventilators. And in 2017, nobody was talking about COVID. There was nothing named COVID before. I was working on the ventilator at this time. Besides my academia career research working in the medical field, I also supporting for some kind of network. I'm promoting network between people, and I'm happy to be motivate people to talk to each other. And I'm also very keen on talking to people, explore new idea, and so chatting around. Right. My motivation was I'm doing that. Why I want to doing this. I was born in the family support. My parents are medical doctors, and I spent time in the hospital more during my childhood. I spent time in the hospital more than in the playground. And I really keen on doing something to benefit my parents. So I want to make them something that they can spend more time for me when I was a child. And then when I growing up and I went into the medical school, and I think this not a good way to help my parents, right? Because I want them to have more advanced technologies. They can spend less time in work, more time as family. So I think biomedical engineering should be the role of my career. So that's why I come into the UK and I do my undergrad in medical engineering. So basically, it's my vision some days the doctor will work less, spend time with their families, their care, their loves more, less time for work, and let the machine do the work for them. So that is the vision for the future that I'm building. So to doing that, I know it's a vision, it's just a vision, but I have a keen vision to focusing on. My work has been, I will tell you a little bit after this. My work is very related to the ventilator, the project that I've been told you at the beginning when I'm doing the PhD. So before that, I think it's a great chance to introduce a little bit about the overall of the talk today. First thing is I will mention something about the University of Oxford here in the UK. Now it's going, and I'm going to talk a couple of the link connection and also talking about a couple of the projects that I've been working on, so we can thinking about any kind of collaboration. Please feel free to email me. About Oxford. So Oxford has been here for a very, very long time. Very long time. The first experience of teaching in University of Oxford was been recorded in PAL 100. So as the first college were being formed in about PAL 100 to 1300 years ago. So it's a long time ago. Yeah. And it's been well known for medical science, physics and math, and also engineering. And that's all about Oxford. Oxford is a combination of very different colleges, and different colleges have different like criteria, rankings, and so they're also very identical to each other. Right. So recently we've been recorded you might heard about Oxford is about the life-saving vaccine for Oxford AstraZeneca. But we have much more than that. We have a lot of things, activities and events. Few things that I want to mention is about the Vietnamese people in Oxford. We have been working in Oxford for a couple of years, but they have been mainly focusing on medical and medical area. And if you are keen to join, we are happy to support. We have a couple of activities in Oxford University and focusing for Vietnam and Vietnamese people. Right now, that's all about the University of Oxford. Here is more about the work, more about the main topics that we discussed today. I told you about my visions about developing the healthcare and healthcare worker, motivate them making better device for medical doctor to use. But in terms of engineering, here is my vision of an engineering in the future. We started by the Department of Bioengineering was placing in the Department of Mechanical Engineering. So at this time, long time ago, people was being divided into different groups. Some of them studied mechanical, some of them studied electrical, some of them are chemical. But now the world has been transformed and it's been translated into something much more complex, and we're facing with very much harder problems. And I believe that in the future, engineering is going into the interdisciplinary. So everything, everywhere, all in one, coming together. One time is going to transform into the transdisciplinary, which is merged together. We all sitting down, people from different backgrounds, solving for one single problem. The work that we're doing in Oxford is focusing on basically it's just like that, digital health. I want to apply digital technology to solving for challenging healthcare problems. It can be very different. It can be therapeutics, digital medicine to tackle couple of challenging situation problems. In 2020, I have developed a group of digital medicine focusing on biomedical engineering in the Department of Anesthetic. So at this time, we're just focusing on any related anesthetics problem that we have. It was a ventilator. It was a quantification of consciousness. I will mention about all of this later. Yeah, it's might be a little bit more technical, but I will try to make it as simple as possible, right? The first project that I involved is InSpeedway. So this one has been involved in 2017 when I first time came into Oxford. So this project has been developed. We try to make a device that delivers a small dose of nitrous oxide into the patient breath. And every single patient breath, we measure the response of the mouth. And by developing the advanced computer model, so we can estimate the lung complexity, we can identify the lung heterogeneity, and we can understand the behavior of the lung just by doing that. And because this is the novel technologies, we coming from the concept, we have to go through the different validation and also regulation process as well. One of the process has been go through the safety, health and safety experiments to test for validation in animal. And we've been working on the animal model. So here is the animal model that we have been working in the pig. We try to compare the technology that we just developed with the gold standard that we have at this time right now is a CT scan. So we bring the pig, monitored by our experiment, our test, and the CT scan. We try to compare and see how the things correlate to each other. Right. But that is where the fun begin, because when we're talking about the experience and we're talking about the technologies, every technology, every measurement, they have an assumption to another, no correlation at all, right? So, and I'm at the time we don't have experience about this, but then we start to develop and we start to understand the system more. We realize that it's just the way how it works. You compare apple to pear, and in the medical world, there's nothing called gold standard. This can be gold standard for this moment of time, but in the next couple of decades, it's going to be vanished very well. Like nobody going to heard about that technique anymore. Even it's well known in the 1970 or 1980. So that is the sorry about that. It's that is the growth experiment that we have been running. So compare the lungs volume of the pigs measured by our technique, and the technique has been considered as the gold standards at this time. And of course, we do develop the mechanical ventilator. We make a ventilator. So during the COVID, there was an Oxfam project that been putting forming together in 2 weeks. And in 2 weeks, we have been forming the ventilator from all the equipment off the shelf. And of course, this group has been led by Professor Andrew Family. He has experience working in making ventilator for the last 30 years. So support expertise, and we were really lucky to have some people who really have the hand-on and know-how experience to help us to really develop the ventilator in 2 weeks. The second project, not related to ventilator at all, the projects that I've been working on is something little bit more philosophy. Sorry. It's about slow wave activity saturation. So we try somehow when during the general anesthesia, when the doctor put patient into SAM, they might have a chance that overdose, which is gives the patient higher dose than they need. And sometimes the other opposite happen, which is given the underdose for the patient to go into this sleep. So the patients actually paralyzed but still have the consciousness level, which is they can understand and they can have a feeling of what have been happened to them during the surgery. And this project have been targeted for focusing on that. We try to go deep into sleep and also mapping this slow wave activity, which is the slow wave activity of the brain when people are having sleep. We try to map these activities into the concentration of the drug. Here is the pharmacokinetic start to kick in when we have to work out the formula for the propofol for the anesthetic agent and some opioid, some drug for the painkiller to make sure that they have the right doses to get into sleep. I involved in this project to design the system for that. So I'm working from the how we're choosing collecting the EEG signal, how we might have a lot of session, how we recognize this noise, how we apply that model, the big machine learning model into the kit and deliver that to the doctor. And sometimes, the doctor is considered as the end user of the system. They might have some very interesting way of requirement for the product. We have been successful putting together a ready-to-use graphical user interface. So the doctor can just plug this machine in and perform the anesthesia. That's it. This can only be been recorded. There's a couple of things that we have been working on, and this project has been still rolling because we care more about the post-operative pain level and also about the level of how people are waking up after the surgery. As we want to get them get up more early, quickly, and healthier. Try to protect their brains during surgery. We have been formula and putting a lot of work to try to understand more about the general anesthesia. Now, previously you was listening to me and I talked about you go to sleep and then the doctor going to do the surgery. But actually, it's not just simple like sleep. Sleep is completely different with anesthesia. And when we understand more about the brain, we're working more on the brain stimulation project. So how to make the brain feel more healthier and how to keep the brain up to date and how we can record any type of two-way activities, how we record the brain, and then how we can interact with the brain. So that's one of the recent projects that I have been working on. Also involved with a couple of my first in human implant for closed loop. So this one is very specific and it's very clinical related. I just want to mention about the varieties of the project that I've been working on. And if you are keen on working collaborate, just come and talk to me. That would be great. Recently, in last couple of months, project that I've been working on is the stroke care in Vietnam. Stroke care in Vietnam is haven't been well established for the last couple of years, but we have been putting together an MOU to try to support the ability to study research and clinical care for people with stroke in Hanoi. We start to have a couple of like events, news, and activities for the people to get involved, have to network, and people who are keen on to the network can participate. And we also have some activities like lecture for to introduce the standard care from the UK to Vietnam. So here's some of the information that we find interesting. So according to our research group, stroke going to be one of the most killing people in Vietnam in 2019. The death because of stroke is 3 times higher than the second one. And it can be the combination of following cause of death. The average aging for the stroke for male is about 55 to 60, and for female is about after 60s. So we was trying to get a standard for stroke care, pre-stroke monitoring and pre-stroke in Vietnam. So make sure everybody is just above certain ages have ability to scan and have ability to get to the better care before the strokes happen. We also looking at about the what is the relationships to stroke, how that's behavior. And the most cause for strokes in Vietnam is high systolic blood pressure. It's the same compared with other country in the Southeast Asia. But one of the more important things that Vietnam we recorded very highly cause of stroke is the dietary risk. Vietnamese people have higher risks because of the dietary to the neighbor, which is Thailand, Laos, Indonesia, and Cambodia. Because we eating more red food, red meat, and then the sodium consumption for Vietnamese people is much higher than the neighbor's country. That's also leading to the cause of stroke because of the dietary treatment. We've been also understanding about so I told you about the stroke situation in Vietnam. So what we want to help, we've been putting together a couple of project study. So, and we now we are learning about what people have been doing here in the UK, in the European, and we found 2 main projects that they have been working. One is umbrella project, and the second one is True Stroke. And I'm going to get a little bit deeper here. The umbrella project is a project when they link the pre-hospitals, in-hospital, and post-hospital all together, and to make a network of hospital and general care, making it seamlessly transfer the patient from one point to the second point to maximize the timing capacity for the patient to have the best care. And the second project that has been developed in the mainland Europe is something called the True Stroke, which is the project has been developed app. And this app, the patient who might have stroke or patient who want to learn more about stroke, how to prevent it, all the information has been be there. And it also can link to a couple of the expertise in the field. Yeah, so that's it for now. Thank you very much for listening. Also talking about a couple of other things, which is a couple of framework and guidelines that are helping for to building how the capacity and research. But I think that will be for the other time to sharing with you. But if you have any question and comment, please let me know. And thank you very much for listening. Yeah, thank you. And now can I return to the MC today? Back to Nhung. Thank you.
Okay, really thank Dr. Rất cảm ơn anh Minh đã với bài talk ngày hôm nay. Thì không biết là mọi người có câu hỏi gì. Nếu mà mọi người có câu hỏi thì có thể raise hands and mình sẽ gọi theo thứ tự. Dạ, mời cô Thanh ạ.
Cho mình hỏi một cái technical là IST versus CT, thì explain cái chỗ đấy một tí với Minh ơi. Cái chỗ IST versus CT.
IST versus CT. First of all, like thì em nói tiếng Việt hay tiếng Anh ạ?
Tiếng Anh.
Right. First of all, the CT they capture the whole lung, so the concept of the CT, like they shining the radiation light through the tissue and get the image. And from the quantitative of the image, we try to predict the condition of the lung. So that's what's normal, the standard protocol of the doctor they've been working on. But for the IST, is a completely different concept. And this is rather big when we try to compare two things together. We cannot find the correlations because the IST concept is not we're not using the same technique, but we're using the transfer gas. So we deliver gas into the lung.
So what is the IST first? You need to define what is the IST.
Inspired sine wave technique.
Okay.
Nó là một cái technique gọi là cho khí vào phổi và monitor cái feedback. Thì nếu mà dùng CT thì khi mà chụp như vậy thì có thể nhìn thấy tất tần tật các cái nang khí. Nhưng mà dùng cái IST thì chỉ có những cái nang khí nào mà thực sự là tham gia trong quá trình trao đổi khí thì mới có thể nhìn thấy. Thì đây là nên là em nói là we compare apple to pear, and we don't know about that. We're very upset with the result at the beginning. Sau đấy là
Okay, so then another question that where you mentioned about the difference between sleep and anesthesia. So what's the difference between them?
Okay, the sleep is actually more complicated, and people are still trying to understand and do more research about sleep. In sleep, people, when you go to sleep, where actually you are sleeping, you're moving through different phases. And the brain, the different phases, they have a different physiology to the human body. Means and in anesthesia, it depends on the doses of the drug that is given, so you can bring the patient to the different steps. But these steps are not the same with the steps.
Do you want to stop to take care of the baby?
Không sao ạ.
His sister, take care of the baby. Yeah, just spend time. We can spend the time. Take the time.
Okay.
So,
cũng không làm gì được đâu ạ. Đó là xin lỗi mọi người.
Không có gì, bây giờ chỉ không biết là có làm sao cho cháu nó đỡ thôi. So okay, anesthesia is a different. Anesthesia thì là depend on the different concentration. We have a different state of sleep or what?
Có thể lên được different, nhưng mà nó không phải là cái sleep staging, nó không phải là cái trạng thái của giấc ngủ, mà nó là trạng thái mà nó sẽ hold đó liên tục. Trạng thái của giấc ngủ mình cứ tưởng là nó sẽ move together, và mỗi cái trạng thái đấy nó tầm khoảng 20-30 phút lại độ trạng thái. Nhưng mà anesthesia là trong cả giấc ngủ, nó sẽ là cái lượng thuốc mà mình đưa vào họ sẽ hold ở mức đó. Thì nếu mà overdose, nó vào một gọi là burst suppression, tức là nó kích thích não bộ liên tục, thì mình cứ tưởng là mình sẽ keep cái brain của mình nó activity là 100% trong vòng là 1 đến 3 tiếng đấy, trong cái lúc mổ đó. Thì nó có một số những cái nghiện liên quan đến cái trạng thái đấy và nó ảnh hưởng khá là tiêu cực cho cái bệnh nhân trong một thời gian dài.
So cái anesthesia đấy em vừa mới you just said is that you have a long term effect. So how long term is that effect?
Long term effect là không phải là long term effect mà nó là cái mà em nói, đấy là cái effect của nó là sau này mình mới nhìn thấy, chứ nó không phải là nhìn thấy luôn.
Chứ
Cái đấy là một cái
không phải là the for months and years effect.
Nó giống kiểu như là hút thuốc lá, 1-2 điếu mình không thể nhìn thấy, nhưng mà nếu mà mình hút liên tục như thế trong tầm khoảng 20-30 năm sau thì mình sẽ có cái effect. Cái đấy nó mới chính là cái cost problem. Và những cái bây giờ nó cũng đang run một cái trial khá là lớn về dementia, tức là trạng thái bị mất trí nhớ và bắt đầu lose một cái activity, các bệnh liên quan đến thần kinh. Thì người ta cũng bắt đầu chase là xem là người đó là như thế nào, họ đã được trải qua một cái cuộc phẫu thuật làm sao.
Ok. Minh em hỏi xem có ai câu hỏi nữa không đi. Minh còn cho em bé.
Cảm ơn anh Minh cho bài tường trình rất là hấp dẫn ngày hôm nay, rất là nói chung là rất là hay, và em cảm thấy là rất là học hỏi được rất là nhiều thứ, và đặc biệt là cái phần ứng dụng EEG và neural network các thứ. Nhưng mà mọi người còn câu hỏi gì nữa không ạ? Cho anh Minh không ạ?
Cho chị hỏi rất nhanh, câu hỏi nhanh thôi. Giờ chị hỏi cái animal study mà em làm trong cái Minipic á, có cái CT scan đó là ở đâu? Tại vì thường là cái CT scan là cho human, mà có cả facility mà để cho animal study luôn là em.
Cái này em cũng chia sẻ với chị, đến đây là Thụy Điển, Uppsala, và Uppsala là có một team chuyên làm về animal, mà đặc biệt là về tick, và họ rất là chuyên nghiệp về lĩnh vực này. Tất tần tật các team của Oxford em thấy là giờ mà cứ sang Uppsala là lại thấy một team UK. Không phải team bên này là bên kia. Họ có khá là nhiều animal model, có từ chuột thì thường là ở đâu cũng có, họ có thỏ, họ có pig, và cái khá là em nghĩ là họ rất là chuyên nghiệp. Chuyên nghiệp.
Còn một cái nữa là cái lúc hồi là tháng 9 vừa rồi là chị có đi Oxford, thì chị có vô cái History of Science Museum. Chị thấy có cái ốc ven ở trong đó, tức là nằm trong cái museum rồi đó nha. Nếu mà em có thời gian rảnh em vào cái History of Science Museum ở Oxford á, là cái Oxford, cái máy, chị thấy cái máy Oxford là họ nằm trong, họ có một cái lồng kính đàng hoàng là để trong cái museum. Không biết em có.
Cảm ơn chị.
Rất là
đấy thì là mới.
Cho nên là rất là thành công trong thời gian mà pandemic, cho nên là chúc mừng. Ok.
Vâng, vậy thì khi ai còn có câu hỏi gì thì có thể liên hệ với anh Minh qua email, hoặc là các cái thông tin anh Minh đã public ở trên của trên
Minh
website.
ơi, em cho email vào đi thì có những người vào sẽ liên hệ được với em.
Dạ vâng, để em xin phép là nhắn lên đây luôn.
Xong rồi là mình close.
Thế là xin phép là em rất là cảm ơn mọi người ngày hôm nay.
Mọi người cảm ơn Minh, cảm ơn chị Đăng. Very interesting seminars. Thank you.
Cảm ơn mọi người đã tôn buổi webinar ngày hôm nay. Chúc mọi người buổi tối vui vẻ. Bye bye.